Let's start. Hi, Harsh. Have Snehal and
Yeah,
Ayush
Snehal,
joined?
Ayush both have joined. Both the examiners have also joined. Anand sir and sir has also joined.
Good afternoon, sir. Prabhu sir and Anand sir.
Are called transposition sling techniques for particular
I will just 1 second. Give me 1 second. I'll
Yes, I
mute.
can. Harsh, can you explain the basic tenets of the
Yeah.
exam online?
So, Anand sir and Prabhu sir, so both of these candidates will present one long case. When they are presenting Ayush, when Ayush is presenting, for example, the questions regarding the case, whatever he is presenting, will be directed towards Snehal. And when she is presenting the case, the questions regarding the same will be directed towards Ayush. However, the type of presentation and what all he has missed while taking the history or examination, those points or marks will be deducted from the person who is presenting himself. For example, if Ayush is presenting AAD and he doesn't tell the congenital features of AAD or the markers of AAD, then that marks will be deducted from Ayush's presentation. But the questions regarding AAD for what is Ellsberg phenomenon or whatever it is will be answered by Snail. The idea behind this is that Snail may have read her own case, but in the exam you will not know what case you are going to get, so you should be able to answer whatever is being provided. There will be two OSCE-based scenarios after this. Once they finish both of their cases, we will start with the OSCE-based scenarios.
Okay. So, Prabhu sir, Anand sir, can we start?
Yeah, sure.
Ayush, you can start your presentation, and I hope Snehal is ready too.
My request is both the candidates, please keep your cameras on because it seems a bit awkward that only the examiners have their cameras on.
Also, Harsh, can you switch off the? Do we have that option to switch off the messages because people in between keep on texting the answers to the questions?
I'll do that. I'll do that. Ayush, you can start, I think.
Yeah. Good evening, everyone. So I'll begin my case discussion. A 16-year-old male resident of Murshidabad, right-handed, was admitted on 20th of June. So the informant for this patient was the self and the father of the patient. The patient presented with the chief complaints of progressive increasing weakness of all four limbs for last 8 years and decreased sensation of four limbs for last 7 years. So the patient was apparently well 8 years
I can't
back.
see your slides here.
So is my screen still not visible, sir?
Ayush, it is visible here. Why don't you unshare and reshare once more?
Sure, sir.
Yeah.
Yeah.
Sir, Anand sir, is it okay now?
नहीं यार अभी भी नहीं आ रहा है हर्ष. It is I can't see his screen.
Shall I log out and relog in?
Yeah. Better, I suppose.
Do that.
Snehal, by the time, do you have your presentation ready?
Yes, sir.
Yeah, can you share your screen just to be sure?
Yes, sir. Yes, sir.
Sir, this is okay, sir.
No, this is not okay. I think I should log out and then I shall just rejoin then.
Yes, sir. Sure, sir.
Okay, sir.
Snehal, usually in any presentation, it is not a good idea to display your own institute. It just creates a bit of bias. So,
Yes, sir.
just for
Yes.
future things, avoid displaying your name of the institute or anything.
Yes,
Yeah.
sir.
Just wait for Anand sir to join and then we'll start. Just give me 2 minutes. Yeah.
Yes, sir.
All the participants, they can feel free to share the link for the Zoom meeting with their colleagues.
I see Anand sir has joined again.
Yeah, now I can see Snehal's slide.
Yeah,
Great,
great.
sir.
Snehal, you start. We will go ahead from here.
So, Harsh, so what I understand is that
Sir.
for Snehal's presentation regarding the history, I shall be asking the questions to Snehal. But for
No, sir.
theoretical questions,
Whatever
No, sir.
she has
asking to-
missed while taking the exam, for example, if she's taking AD and she's missed taking something, then that is Snehal's fault. So that marks will be cut from Snehal's presentation.
Okay.
However, regarding any questions ki why does AD present with one hand weakness or something like that, those will be
That shall
directed
be
towards
directed to
the
Ayush.
yes.
All questions first to Ayush. If Ayush is not able to answer, sir, the question comes back to Snehal.
Okay.
Yeah.
Okay.
You can start, Snehal.
Yes, sir. Good afternoon, sir. My patient is 19-year-old female, right-handed, resident of Jalgaon, Maharashtra, third-year engineering student. History given by complaints of neck pain since 1 year, weakness in left upper limb since 6 months, tingling in both upper limbs 6 months. During back when she experiencing neck pain, which was onset, first felt in the morning after getting up from sleep. Lasted for 15 coughing or straining, and she also recalls pain after lying to moderate and no history of neck trauma, neck tilt or clicks. Patient
Snail, why don't you switch off your video? I think your signal is very poor, I suppose. Just switch off your video.
I'm
Just
able to
be
hear
on
you
audio.
properly.
Yeah. Now just start to speak again. We'll see.
patient recalls occasional dropping of objects from
better.
left hand. Patient
Continue.
recalls occasional dropping of objects from left hand since 6 months, insidious in onset, gradually progressive over a period of next 2 to 3 months, when she started experiencing reduction in grip of holding objects from left hand while holding water bottle, difficulty in holding scale from left hand while drawing, difficulty in tying shoelaces. At this point, she was able to do all her routine activities independently, but with some difficulty. Since 2 months, symptoms progressed, and she first noticed that she was unable to comb her hair with left hand, unable to tie her hair with left hand. She was unable to reach overhead shelves. She also complains of thinning of left hand. No history of weakness on right side of body. No history of difficulty in turning side to side on bed. No history of getting up from bed from supine position with support of both hands. Patient started experiencing tingling sensation in both upper limbs, insidious in onset, gradually progressive. This tingling sensation was going from elbow to wrist joint, sometimes from arm to hand, relieved on its own after some times, not associated with numbness. Urinary dysfunction. Patient also complains of urinary dysfunction since 2 months in the form of increased urgency and frequency. The patient has sense of complete evacuation, can feel fullness of bladder and has good flow of urine. She also has sense of complete evacuation after passing urine, no history of urinary incontinence, dribbling of urine. She also started experiencing slippage of chupples from her foot since 1 week. She did not have immediate realization. She complained of giddiness when she was trying to wash her face and had difficulty in walking in dark rooms. No history of abnormal twitching of limbs, no history of involuntary movements of lower limbs in supine position and sitting with feet hanging from bed, no history of fall on uneven terrain, no history of inability to negotiate from narrow corridor, no history of band-like sensation on chest or abdomen, no history of current-like sensation on flexing neck, no history of painless cuts and burns, no history of cotton wool sensations while walking. Patient can feel clothes over her body and can differentiate hot and cold water while taking bath. No history of constipation, no history of evening rise of temperature or chills, weight loss. No history of difficulty in turning neck from side to side. No history of difficulty in shrugging shoulders. No history of swallowing difficulty. No history of breathlessness. No history of facial burn or abnormal sensation on face. No history of facial deviation or drooling of saliva. No history of tongue deviation or abnormal tongue movements. No history of change in voice. No history of loss of smell, diminution of vision, restriction of eye movements, abnormal eye movements or deviation of eyes. No history of loss of taste of food. No history of similar complaints in the past, no history of hospitalization or TB or trauma in the past. Patient denies addiction, consumes mixed diet. She has regular menses with normal flow. No history of similar complaints in any family members. So to summarize, 19-year-old female with complaints of neck pain since 1 year, progressive asymmetrical left upper limb weakness since 6 months, tingling in both upper limb with reduced sensation in left hand since 2 months, urinary urgency and frequency since 2 months, slippage of chapel from left foot since 10 days, no bowel and no cranial nerve deficits.
Well, you can continue, I think.
Substrate localization, corticospinal tracts, posterior column and bladder fibers are involved. Vertical extent from below CVJ to C5. Horizontal could be either intradural, extramedullary, intramedullary or extradural pathology.
Okay. What are your different?
Yeah, Harsh, can we ask questions now?
Yeah, sir. You can ask, interject in between. It's just like a normal long case.
Okay.
Yeah. You can just ask anytime.
Okay. So, Ayush, do you agree with the substrate and the localization that Snehal has put up?
Yes, sir. So, like in the vertical extent, it's written over here below CVG2 to C5. So I can only localize from the history that it probably comes down to C5 level vertical extent. Why it comes down to CVJ over here still remains a query mark as per the history, because there are no features of like lower cranial nerve involvements or any spastic pattern of paralysis as that can be seen, which would show you inverted U-shaped pattern of weakness. And so the features are not very much suggestive of the CVJ junction as of now, only from the history, and mainly localizes to C5 on the basis of history that she was not able to raise her hands. So that localizes. And also regarding the horizontal level, so from the history, like since the bladder involvement has been there and it has been comparatively an early bladder involvement, it favors the intramedullary pattern of weakness. And also regarding the pain, so the neck pain, we could not actually characterize the pain from the basis of the history, whether it was a lacerating pain or a deep dull aching pain, as we see normally in case of an intramedullary lesion, which would usually present the deep dull aching pain and a dermatomal pattern. And in case of an extramedullary, it would be more of a uh, root pain, that would be a lacerating pain. So over here, the horizontal extent still remains more towards the intramedullary, only considering the bladder feature, and the uh, basis of the sensation that was over here only the posterior column, like the patient was not able to patient had a swing sensation while washing face, so that only over here uh, portrays towards the posterior column. And also regarding the bladder, I think we need to mention over here, it would be an upper motor neuron bladder from the history, because of the presence of the urinary hesitancy or urge, and the other features like the incomplete evacuation and all basically rules out the possibility of an element bladder on the basis of history right now.
Okay, Ayush, if you can localize above C5, but you don't know what is the upper extent of the pathology. So she has put it as CVJ. So why do you think it
Below
cannot be
CVJ.
So
yeah,
it can
below CVJ and above C5? So Snehal, why do you want to put it below CVJ? Because Ayush says he cannot localize it below CVJ. He says he can localize above C5, but he can't localize the upper extent as below CVJ. Snehal?
Yes, sir.
Yeah, why you are localizing it below CVJ, above C5, but Ayush says
Yes,
that
sir.
above C5 is fine for him, but he is not agreeing to the point of below CVJ. So why do you want to put the upper extent as below CVJ?
It is upper cervical cord or like C5, C6 level above that. I cannot localize to any particular level from the history.
No, that is fine. Okay, then let me ask you some. Ayush, if you have to localize, let us say for just the discussion purpose, it is below CVJ and above C5. Okay.
yes
How
sir.
can you further narrow it down? What all things in history should be taken to narrow it down further?
So, if I want to localize it to your high cervical, so normally this CBJ would be having a spastic quadriparesis, usually involving the entire, all the four limbs, which will have a classical pattern starting from one limb going to the other and following this. Also at CBJ, the patient would be having features of the lower cranial nerve involvement. So over here in the form of lower cranial nerve
No,
involvement.
Ayush,
Not necessarily.
not necessarily. No? Just sorry to interrupt you. You would have seen many cases of AD. Those patients, they don't present with lower cranial nerve involvement.
Yes, sir.
So it is not that CVG involvement has to mean that lower cranial nerve has to be involved.
So agree, madam. Those are the
And
points like
what my
which would.
question is, if you have to see many times, your localization is above C5 and below CVJ. This is the
Yeah.
usual
So also the
localization.
respiratory involvement over here. The patient might be giving history of respiratory distress on performing small amount of not on small on walking a few steps, or patient would be having respiratory difficulty over here.
Or respiratory difficulty. See, you have to understand, Ayush, respiratory difficulty is a very broad term.
Short
Any
term,
patient
right?
who has anemia will have respiratory difficulty. Any patient who has cardiac causes will have difficulty in walking few steps. So what is specific about the respiratory difficulty that you're talking about in a patient who has a high cervical myelopathy? You're getting my question?
Like yes, sir. So the patient is usually not able to walk at a long distance in a single uh, at a single time and gets exhausted very fast.
Anyways, so
And
my question is,
involvement of
how do you
the
localize it?
accessory muscles of the respiration, like he has to make more efforts for his respiration, and the accessory muscles comes more into play during his respiration pattern.
Ayush, doesn't that happen in a very advanced stage? And why are you assuming that craniovertebral junction patients will have respiratory difficulty? In fact, how many of them do you see with respiratory difficulty?
Right, so
That's a very advanced stage of involvement, no?
okay.
See, Ayush, moreover, what we want to ask is that how do you localize below CVJ and above C5. C1 पे कैसे आप पूछते हैं, C2 पे what is the history for C2, C3, C4, C5?
Yes, sir. So it could be on the basis of the neck movements and the loss of sensation on the occiput region or the lateral part of the uh, neck and the upper part of the neck, if there is any loss of sensation over there, or if he has difficulty in flexing his neck or extending his neck.
So flexion extension is, if the patient has difficulty in flexion or extension, what does that connote?
So like the flexion and extension over here, I'm basically more heading towards the involvement of the upper neck muscles over here, like in the neck flexion, the role of the sternocleidomastoids, and the extension part, specifically the trapezius muscle.
Trapezius.
Eh,
See, what does the C1 root value does? It causes flexion extension, it causes lateral bending, it causes rotation movement. What does C2 do? What does C3 do? Apart from that, what all nuclei, what all cranials can you examine in a high cervical myelopathy?
In the higher cervical, we can examine the trigeminal nerve.
So you have to tell all these things now. So till what point does the spinal nucleus of trigeminal nerve
So
come
it
down?
extends up till the C4, it extends down to C4.
So what will happen if the patient has a spinal nucleus of trigeminal nerve is involved? What will happen? How will the patient give the history? What shall be the findings?
So if the trigeminal is involved, the patient may give the loss of sensation over his face, uh, and also give history of difficulty in difficulty in chewing food.
No. I usually you're going the wrong way. Loss of sensation in the face in what particular pattern? Say for instance, a patient has a trigeminal schwannoma, or a patient has some, say for instance, any lesion which is causing compressing the fifth nerve in the subarachnoid space, vis-a-vis a patient who has a high cervical myelopathy. The sensory loss or the sensory disturbance would be same in both the cases, or will it be different?
The difference of the onions, it follows a particular pattern of
What
like in
pattern?
the onion peel skin appearance pattern.
What is that?
The patchy loss, not.
No, it is not patchy. Anyways, you go and read about it. Okay. So one is trigeminal nerve. Anything else you want to examine in a patient who has high cervical myelopathy? So when you told about the movement of the neck, okay,
Movement of the neck.
You should know what causes C1, what causes flexion extension, what causes a lateral bending, and what causes rotational movement. Okay, which nerve roots they are involved in that.
Also,
Okay,
the C.
so you read
So
about that.
C1 is basically the motor component, having the motor. The C2 root value basically is more towards the causing the flexion, and the C3 is doing the lateral neck movement part.
Santosh sir, please, you want to ask something else?
See, it is, in my opinion, it's very difficult to localize so precisely at all these levels. It's very difficult to elicit this history and get this kind of a localization. So C5 to craniovertebral junction, the whole band is extremely difficult to localize. Like you rightly said, if there are no cranial nerves involved, then the pathology is below the foramen magnum or at the craniovertebral junction. But to get it further between the craniovertebral junction and C5, it's extremely difficult to localize. Would you agree with me, Dr. Anand?
Yeah, yes, sir, sure, sir. My only point was that they should know what all things they should ask so that they can, if possible, they can just try to narrow it down as much as possible.
Correct.
So, okay, so can you move on to, can you move to the next slide, please? Santosh, sir?
Sorry, come again?
Yeah, what I'm asking is, can you move to the next slide, please?
Yeah, we can move ahead.
Okay. Yes, Neha, please present the examination part.
On examination, the patient is average build with normal hair and skin sitting in a comfortable position. Pulses 68 beats per minute, regular, normal volume, character, rhythm. All peripheral pulses felt equally and symmetrically. with no radial delay. BP was 112/60 in supine position. Respiratory rate 18 per minute. Regular thoraco-abdominal with no paradoxical breathing. Height 164, weight 68 kgs. Neck length was 10 centimeters. Hairline was normal. External ear level is normal. No ulcer or trophic changes seen. Gait was normal. No high arch palate, web neck, cleft palate. No pallor, icterus, cyanosis, pedal edema, clubbing, generalized lymphadenopathy. On examination of spine, no evidence of spinal dystaphism or other neurocutaneous markers, no neck tilt, no spinal tenderness, no scoliosis, no signs of meningitis. On systemic examination, trachea, central respiratory system trachea was midline. Chest movements appreciate normally and equally bilaterally. Thoraco-abdominal respiration, no paradoxical chest movements seen. No use of accessory muscle seen. Breath holding time was 42 seconds. Single breath count 38. On CVS examination, apex palpable in the fifth intercostal space, 1 centimeter lateral to no cardiomegaly. S1, S2, no added sounds. Abdomen soft, non-tender, no organomegaly, no palpable mass. Bladder was palpable, normal. Nervous system examination, higher mental function normal. MMSE 30/30. Cranial nerve examination, olfactory nerve normal. Optic nerve was also normal. Cranial nerves 3, 4, 6. Extraocular movements normal. Nystagmus absent. Diplopia absent. Pupils normal shape and reacted bilaterally. Ptosis absent. Accommodation reflex normal. EOM was full in all directions. Pupillary reactions, direct reflex, indirect reflex present. Trigeminal nerve, bulk normal of masticatory muscle. Side to saw jaw movement normal. Sensory pinprick temperature, fine touch normal. Corneal reflex, direct, indirect normal. Jaw jerk absent. Motor normal. Sensory taste and sugar and salt normal bilaterally. Vestibulocochlear nerve, Rennes normal. Weber's normal. Glossopharyngeal and vagus nerve, well, uvula is in midline and at rest and on phonation. Gag reflex normal bilaterally. Spinal accessory nerve, trapezius equal shrugging of shoulders. Sternocleidomastoid equal adequate strength on both sides. Hypoglycal nerve, no deviation of tongue on protrusion. No atrophy or fasciculation. On motor examination, muscle bulk, above elbow on equal on right and left side, below elbow. Thenar and hypothenar muscle wasting was seen on left side, left hand. Below knee, above knee bulk was not equal on both sides. Tone was raised in all four limbs, modified Ashworth grade 2. Power, shoulder, abduction of shoulder, right side power was 5, left side was 2. Adduction, right side power was 5, left side was 3. On flexion, right side power was 5, left side was 3. Extension, right side was normal, left side power was 3. Elbow, flexors, extensors was normal on right side, left side power was 3. Wrist flexion extension normal on right side, left side power was 3/5. Finger flexion extension normal on right side, 3/5 on left side. Hand grip was strong on right side, moderately on left side. Power of hip, knee and ankle was 5/5. Reflexes, superficial abdominal reflex absent. Plantar reflex bilateral extensor. Deep tendon reflexes, biceps hyporeflexia was seen. Left side plus supinator just was absent right side. Left side inverted supinator reflex was seen. Triceps exaggerated, left side exaggerated. Hoffman was normal on right side, left side Hoffman sign was present. Knee jerk and ankle jerk exaggerated on both the sides. Sensory examination, pain and temperature reduced by 50% below C5 level. Crude touch was normal, fine touch normal, vibration and joint position sense was normal on both sides. Cerebellar examination, finger test, dysdiadochokinesia was normal, heel knee shin test normal, gait and stance was normal, Romberg sign was positive. Provisional diagnosis, lesion was localized to C5, C6, horizontal intramedullary SOL, also intradural.
Okay, okay, thank you. Ayush, do you agree with the localization, or would you like to change something, or and then do you agree with the possible pathology? If yes,
Sir,
then why, and if not, then why?
so like over here in the examination part, there has been a new point added regarding the pain and the touch, which was not evident from the history. However, it has been present uh, in the examination part, and also in examination, the joint sensation and all was like no findings were found to be positive in case of the posterior column findings in the examination. So from considering the history in the examination, now we have the two tracks involvement, spinothalamic and the posterior column. So, and along with this, there is the involvement of the bladder. So yes, I would go for the horizontal level more towards the intramedullary as well. And the localization of the lesion, yes, it would go down to the C5. And I would add over here that the autonomic features, symptoms are present in form of the bladder involvement, which was mentioned in the history.
What are the points against intramedullary tumor or intramedullary lesion?
So the points against the intramedullary lesion uh, would be the pain which the patient had. Normally, an intramedullary as well would present with a funicular type of pain, which is a dull aching pain. Also, against would be so that is one of the most strong points, like the intramedullary as well would be the pain and also the pattern of involvement. Usually in
What pattern of
intramedullary
involvement?
bladder symptoms usually come first, but
They
over here
don't come first, they come early.
they come early, right?
Okay, so that is true for this patient. And in the history of about 3-4 months, the bladder involvement is there for about 15 days or 20 days, something of that sort. Okay, in intramedullary pathology, the likelihood of being both the sides being equally involved is more, or they are more likely to be asymmetrical.
So please could you repeat? The first part just got cut, sir.
In an intramedullary, in this patient, the patient has left-sided weakness of about 2/5 or 3/5, in left upper limb.
Yes, sir.
But right side power is 5
It
by
is
5.
yes. So it is an asymmetric.
So you think
Weak.
asymmetricity favors intramedullary tumor?
It goes against.
So that is what you have to tell, na?
Fine. Sorry, sir.
So much of, see, this slight asymmetricity, na, 4/5, 4 plus by 5, or 4/5 and 5/5, that can be fine. But a patient has power of 2 to 3/5 on one side and has power 5/5 on the other side, that goes strongly against an intramedullary tumor.
Okay, sir.
Okay.
Sir, also the favor would be the dissociative anesthesia, because like some parts of the sensation are involved, some parts are not involved.
That is
So
fine, but the problem with this is the only pain and temperature is involved. Nowhere in the body there is any other sensory loss.
yes, right.
That is very unusual for an intramedullary tumor. That is fine. Dissociation is there, but dissociation is usually limited.
Okay, sir.
Okay, so here the patient has only pain and temperature loss. History has the patient gives history of posterior column involvement, but for some reason the posterior column involvement is not there on examination, which is quite unlikely. I would advise Nehal to just re-examine the patient again, because it is unlikely that the patient gives history of a posterior column involvement, but there is not even a single finding suggestive of posterior column
Romberg
involvement.
sign is positive.
Sorry?
Romberg sign is positive, sir.
Romberg sign is positive. Okay. Okay. So you want to add on to some other pathologies like ependymoma, mastocytoma? Any other pathology you would like to add? Ayush?
So now if I'm considering the intramedullary as well only, I can add METs also, sir, or myxopapillary.
Myxopapillary at C5 C6 levels, that is not acceptable, na? Ependymoma, mastocytoma, any other intramedullary pathology that you can name?
As of now, I'm able to recall this myxopapillary ependymoma, astrocytoma only.
Okay.
Some like
Can
the other
it be
extramedullary tumors, like that could be a meningioma or a neurofibroma or schwannoma. So since as we have, so it can have like a compression on the cord from the extramedullary part and not exactly an intramedullary. So it could be the extramedullary thing which is completely compressing the cord, and
Then you
that can
yeah, then you can
that
have that is an extra medullary pathology.
medullary, right?
You can have an hemangioblastoma. You can have a
Hem-
localized syrinx.
Localized serings, right?
And hemangioblastomas also, they can also present in similar fashion. Now the point is, why has she localized at C5 C6 level? What are the point in favor of C5 C6 level?
So the points in favor of C566 level, from the history, the patient had started was having difficulty
No,
in
on examination.
on examination. The reflexes are exaggerated. The biceps reflex, the triceps reflex, and all these reflexes are exaggerated. So
No. Ayush, if the biceps reflex is exaggerated, then the pathology would be at what level?
since the root value for biceps would be like C5, C6. So the
If the
pathology
bicep reflex is exaggerated, then the pathology has to be at what level? Above what?
is above C5, sir.
So C5 C6 cannot be the localization, now.
Localization. So she has also put that inverted supinator.
She has, no, she said that biceps is +1. If I'm not mistaken, Snehal.
Yes,
Yes, sir.
yes.
Yes, sir. Yes,
So
sir.
biceps is +1. Okay, so biceps was diminished and inverted
Inverted
supinator.
supinator reflex
Uh, so,
that
uh,
basically
so,
localizes to C5, C6.
so now because biceps is diminished and supinator is inverted supinator, that
So
actually favors the
C5, C6
C5,
localization.
6.
C5 C6. Okay.
Yes, sir.
Okay. Yes, Santosh sir, please, you would like to ask something?
Uh, basically, the history doesn't suggest intramedullary involvement at all. It's very asymmetric. Uh, the reflexes also are, the power loss is also essentially on the left side. So it seems more like an intradural extramedullary tumor from the findings and the history, isn't it? Hello?
Yes, sir. Some of the points are not very much favored in either for the intramedullary or extramedullary, but considering the pattern of weakness, as you told, sir, it does point towards the extramedullary component.
Correct. Anyway, I think we can move ahead, Dr. Anand.
Yes, sir. Sure, sir. Yes, Snehal, please go ahead.
Yes, sir. These are the scans of my patient. This is MRI T2-weighted sagittal cut showing cord expansion from cervicomedullary junction to D3 level. Syrinx is seen and hyperintense lesion seen on C3, C4 level.
Okay, Snehal, any other radiology do you have, or this is the only radiology?
Sir, this is a post-contrast image.
Okay.
Showing lesion in from C2 lower border to C3, C4, C5 upper border, along with cord edema. This is the axial post-contrast cell.
Okay. Okay. So, can you see? You said that from CVJ to C5 now,
Yes, sir.
but the pathology is going above C5. It is going
Yeah.
up.
Yes, yes, sir.
So it's strange that there are no medullary
Yes, sir.
signs, Very
Yeah,
strange.
absolutely. It is very strange that the patient doesn't have any medullary signs or lower nerve involvements.
Correct.
The patient was well preserved.
Okay.
So here, even the
Ayush,
lesions
what
are
is
there
your
in the. Oh, sorry, sir.
Ayush, what is your differential at the end of the now the radiology is also in front of you.
Hmm.
What is the differential diagnosis now?
So my differential diagnosis right now would be a intramedullary as well, intramedullary as well, or it could be a syrinx along with syrinx. So an intermediary as well, it could be as well told like ependymoma, hemangioblastoma, or astrocytoma.
No, in this case, you would like to keep ependymoma, hemangioblastoma, and astrocytoma in this sequence, or you would like to change the
No,
sequence?
so I would change the sequence. I would keep first myxopapillary ependymoma, followed by astrocytoma, and then I would like to keep hemangioblastoma.
Why are you saying it mesopapular ependymoma?
So I'm saying it myxopapillary ependymoma because in intramedullary that is one of the most epidemiologically commonly seen. Also here I can see like in the contrast uptake, during the contrast uptake there are some patterns of no contrast uptake. So could be some cavitary lesions inside the particular tumor, which is usually classically seen in this myxopapillary ependymoma. So that other
No,
points.
I'm not doubting you why you're calling it ependymoma. What I'm asking is why are you calling it mesopapular ependymoma?
Um,
According to you, is mesopapular ependymoma and ependymoma synonymous?
the histological pattern, the presentation would be grossly same, and that we would be able to differ mainly in the histological part.
No, Anant, I think what Sir is trying to say is, do you know of any other ependymoma apart from myxopapillary ependymoma? Any other type of ependymoma? Have you heard of any other type of ependymoma?
One is myxopapillary classic anaplastic ependymoma.
So, what would you think that this would be more likely to be?
Okay. So like the variations even the it extending up above also, so could be an anaplastic variant. Like I'm not very sure on radiological basis how to differentiate it, sir.
Santosh, sir, do you want to ask anything from Ayush now in as far as radiology is concerned?
I wanted to know why he thinks this is a hemangioblastoma.
So hemangioblastoma because of the presence of a cyst within the tumor, or that's like how normally hemangioblastomas usually present with the a cyst, a surrounding mural nodule, and a cyst cavity. So since could be a suspected cyst cavity, that is why I thought it to be a hemangioblastoma also.
But does this look like a mural nodule to you?
No, not exactly, sir.
So I wouldn't even consider a hemangioblastoma in this.
Yeah, this is not likely to be an hemangioblastoma.
Correct.
What all other things you see when you told is a mural nodule? Any other thing which favors the hemangioblastoma? Not in this case. In what are the other hallmark features of hemangioblastoma?
Besides, see, you said that the clinically the patient has an asymmetric signs, right? So ependymomas are usually starting in the center and extending more peripherally. So usually the clinical picture and power loss is symmetric. So in view of this, would you like to, change the order in which you are putting your diagnosis?
So like considering the point that we gave, if we case in, then astrocytoma would be kept above ependymoma.
Correct.
Understood.
Okay. Ayush, what would you do for this patient? What shall you plan for this patient?
With the history, clinical examination, and my imaging, first I would like to discuss my treatment plan with the patient. So considering that she's a young female with a neurodeficit present in form of weakness, I would offer her the operative intervention over here for the patient. I would also at the same time explain her while I do the plan for the operative intervention, the possibilities that I might not be able to take out the entire tumor, and the need for the neuromonitoring intra-op, and that there might be need for post-operative radiation therapy. So having explained to the patient and with due consent, I would like to proceed for this patient in the presence of intraop neuromonitoring for the excision, the safe possible maximum limit of the resection of the mass, followed by awaiting the biopsy report, and on the basis of the biopsy report, plan for further.
Okay. What surgery would you plan for this patient?
So I would.
What is the goal of your surgery, Ayush? In
So my
this,
goal of surgery over here would be my primary goal would be over here biopsy and to decompress as much as possible, because it is if it likely appears to be intermedullary with the cord expansion and the nerve roots might be involved, so I might not be able to have the full dissection. So my goal over here would be mainly a decompression and getting a biopsy, ensuring that I don't give any new neuro deficit to the patient. That would be my goal, and I would go via the posterior approach that we have commonly seen.
So what posterior approach? Ayush, can you just like C2 laminectomy, C3 laminectomy, C2
Sir,
C3
so
laminectomy?
so over
What
here,
what what do you want to do?
so over here, my tumor with the maximum contrast uptake is from C2 lower body extending up to the C4 lower body. So I would want to do a C2 to C4 and a part of C5 laminectomy, get the normal uh, part of the tumor, and C2 to C5 laminectomy, and I would like to proceed, sir.
Laminectomy or laminotomy? What I couldn't get you. I said laminectomy.
C2 to C5 laminectomy followed
Okay.
by durotomy and getting the in the presence of intraop neuromonitoring,
Okay.
getting
What
the
intraoperative monitor do you use?
so I'm not able to recall exactly. We don't use neuromonitoring in our institute at present, so I'm not seen it, so I'm not able to recall any of them.
Okay, Snehal, can you answer this question? What all neuromonitoring would you want to use in this case?
Sir, we'll use MEP, specifically D wave in this.
Okay, what shall be the problem of using the D wave in this case?
Um,
Okay, so you want to use MEP and D waves.
yes, sir.
Okay. Okay. So can we move to the second case now? Harsh, can you move to the second case now?
no, I just want to, Anant, I want
Yes,
to
sir.
add something here.
Sure, sir, please.
Yeah, see, as far as we are concerned, and as far as intramedullary tumors are concerned, your goal is to do a total excision of the tumor without inflicting any neurological deficits. If you go in with a goal of only taking biopsy and partial decompression, you will not ever be able to achieve a total excision. At our center, we are excising all intramedullary tumors totally without inflicting any additional neurodeficits, because the best chance for the patient to have a total excision is at the first surgery. If you are timid in your approach and only biopsy the tumor and take out part of it and leave rest of it there, the patient will not do well clinically, and post-operatively, God forbid, if he requires another surgery, then the second surgeon job becomes very, very difficult. We see so many of these patients. So I would like to say that the goal is a total excision without giving any neurological deficit. And if you do it very, very carefully now, with the availability of intraoperative neurophysiology monitoring, this goal is always attainable. You can check up the literature. Partial excisions do not do well as far as long-term results are concerned.
Okay,
Yeah.
sir. Okay, sir.
Yes, I completely agree with you.
Yes.
Your aim should be to take out as much of tumor as possible without giving any new neurological deficit. And with the presence of IONM, you can achieve that much, that complete excision in many cases. In some cases, you might be unable to do that, but your approach should be to try to debulk the tumor as much as possible. Harsh, can we move to the second presentation or?
Yes, sir. We can go ahead, sir. If
Okay,
nothing else
so
needs to, yeah, we go
Snehal,
ahead.
you can stop sharing your slides, and then Ayush,
Yes, sir.
you can start sharing yours.
So shall I start my presentation?
Yes, please.
My patient, 16-year-old male, resident from Murshidabad, right-handed, informant being the self and the father of the patient, presented with the chief complaints of progressive increasing weakness of all four limbs for last 8 years, decreased sensation of all four limbs for last 7 years. So weakness was insidious in onset, noticed first 8 years back with the involvement of his right lower limb. The patient experienced a feeling of heaviness and stiffness of the right leg and dragging of the entire limb while walking. He had difficulty in climbing stairs, rising from a sitting or squatting position, wearing his trousers independently. There was no history of high stepping gait, slapping of foot on the ground, or any frequent tipping. Weakness then progressed over the next 7 months to involve his right upper limb, where he was unable to mix food, break roti himself while eating, hold pencil, spoon, and had difficulty in writing, difficulty in opening bottles. He was able to bring his hand to his mouth, but over the next 1 year, he was unable to unbutton his clothes, brush his teeth, comb hair, and lift his arm above the head while putting any object at a height level. The weakness then progressed to involve the left side upper limb in next 3 years, where he was unable to mix food, break roti himself while eating, hold pencil, spoon, and had difficulty in writing, and then the left lower limb since last 2 years to limit his daily activities and making him dependent on his parents. Weakness was more on right side compared to left side. It is associated with difficulty in walking since last 2 years, where he has to drag his leg while walking, but not associated with any spinning of head, swaying from side to side, any spontaneous nodding of head, movement of limbs, any intention tremor, or difficulty in reaching out for object. It is associated with thinning of both hand and muscles since last 1 year, and there is a feeling of tightness when he doing the movement of his limb. There is no associated history of any other abnormal movements or sudden jerks, no history of any associated trauma before the onset of symptom, fever, neck pain, or any relieving or aggravating factors for the same. He also gives a history of decreased sensation, which was insidious in onset, first noticed 7 years back in the right upper limb in the shoulder region, where he could not appreciate hot and cold water while bathing and frequently sustained unnoticed mosquito bites. He also perceived touch over the right upper limb to be diminished compared to the opposite side while he used to put on his clothes. He subsequently noticed that when he was touching the area of his shoulder, there was no feeling of touch and subsequently noticed this loss of sensation over the entire upper limb. Gradually, this progressed over the next few months to involve the entire upper limb. There was no history of any burn or ulcers. Over the next few years, similar symptoms appeared in the left upper limb. Subsequently, he developed diminished appreciation of pain and temperature in the right lower limb, followed by the left lower limb over the ensuing years. There is no history of feeling of walking over soft cotton surface, imbalance while washing face, appreciating position, difficulty in walking down, or appreciation of position of limbs while lying. No history of suggestive of numbness, tingling, pin and needle sensation, band line sensation around trunk, electric shock sensation on neck movements, perianal sensation, loss of sensation over face. There is no history suggestive of any bowel or bladder symptoms, no history of any dryness of mouth, face, eye, or excessive sweating, no history suggestive of autonomic dysfunction, including loss of early morning erection, no history of seizures, no history of any cranial nerve involvement, no history suggestive of fluctuation or diurnal variation of symptoms, no history of any respiratory distress or recurrent respiratory tract infections. Past history, no history of tuberculosis or any other hospital admission, no surgical interventions done in past, non-diabetic, non-hyper tenses, studied till class 3, average Bengali diet, normal developmental milestones, no history of any major or similar illness in family, and there was no significant drug or any allergy history. So to summarize, 16-year-old presenting with gradual, progressive, asymmetric, non-selective, spastic quadriparesis involving both distal and proximal muscles, starting from the right lower limb to involve the right upper limb, followed by left upper limb and the left lower limb, affecting gross and fine movements of hand, thinning of hand muscles, difficulty in walking without foot drop, affecting pain, temperature, diminished touch sensation, first affecting in right upper limb, then in left upper limb, with sparing of position, vibration sense, and no involvement of autonomic functions. So the vertical extent from query C4 to C8 T1, horizontal extent being probably an extramedullary, I'm having an upper motor neuron lesion plus a low motor lesion, predominant involvement of the corticospinal tract as well as spinothalamic tract, and also maybe involvement of the posterior column tract involvement.
So Ayush, you mean the pathology is between C4 to C8 level or T1 level?
So as per the history, that is what
as
I
per the
could
history, this is what you interpret.
that is what I could localize to,
Okay.
because I was not getting any other features where I could localized to the above the C4 level. And as you had mentioned in the previous case, the history of loss of sensation over the face or the involvement of the lower cranial nerves as in the CVJ part or the neck movements. So hence, for now, I've kept my vertical extent localization to C4.
Okay. Snehal, do you agree with the subset analysis of Ayush, or you want to add or change something?
Sir, I think upper cervical involvement we cannot rule out from the history, sir. It could be from upper cervical cord also might be the pathology, sir.
So what would your vertical
It
extent be?
has spastic quadriparesis, sir, or of all four limbs.
Yeah, I agree with you. So what shall be the, if you want to localize, then what would you say? What would be your vertical extent? What shall be the topmost level? What shall be the lowermost level? Like he's
So
saying
CVJ C5.
CVJ to C5. Okay.
Yes,
Why
sir.
do you think so?
So from history, sir, we cannot rule out the not involvement of it is upper cervical cord involvement from the history.
Okay, and do you agree with the horizontal involvement, extramedullary pathology?
Yes, sir.
Why do you say so?
So it could be extramedullary or intramedullary because there is loss of pain, pain and temperature. But the hot and cold fibers are affected. Patient is not able to feel temperature. So spinothalamic crossing fibers could be involved. So I would like to keep intramedullary also my differential. Pathology could be extramedullary or intramedullary. Cannot rule out from the history, sir.
Okay, he has a very peculiar history. The patient starts weakness in the right lower limb, then the right upper limb, then the left upper limb, and then the left lower limb. So how do you explain that?
Sir, inverted U-shaped weakness is present in this.
That is fine. How do you explain that?
Localizing to upper
Where
cervical
do you
cord.
think is the pathology?
Sir, after the crossing of both the upper and lower fibers, pyramidal fibers,
Okay, so where do they cross?
it is involving right lower limb,
Right lower limb, then the right
lower
upper
body
limb.
of medulla, sir.
So if your
Then
localization,
left upper limb and then left lower limb.
yeah. So if your localization is at the lower level of medulla, then so your localization goes to
So after, so below the crossing.
Okay. So, and what about the sensory loss? The patient has sensory loss first in the right upper limb, then in the left upper limb, and then it goes to the lower limbs. Am I correct, Ayush? This was this.
Yes, sir. This
Yes, a
basically
descending sensory pattern is
the sensory part is different from the pattern of the involvement of the motor part.
First, the right upper limb was involved in the sensation,
And then the left upper limb was,
then left upper limb,
yes,
and then
and
both
then
the lower limbs.
then both the lower limbs, right, sir?
So, Snehal, where do you think is
the
the pathology?
descending paresthesias are seen in intramedullary tumors, sir.
Yes.
So, in intramedullary tumor, but the weakness will start with the lower limb.
No, sir.
So, what do you think is now? It is
Both extramedullary plus intramedullary.
Extramedullary more than intramedullary, sir.
okay. Santosh, sir?
So
Sir,
you're not
you have to
audible.
unmute yourself, sir.
You said there is you said there is posterior column involvement, but nothing in the history suggested posterior
So
Hmm.
the sir, I had the reason I put the posterior column involvement was like regarding the touch sensation when he was, I mentioned, right, when he was putting on the clothes and he was unable to appreciate that the clothes were there and the touch eventually. So now only considering the touch, whether I should say posterior column involved or not, that is a query mark. And hence I have just put on the basis of only one modality of the posterior column, the touch, specifically the fine touch over here, where he says that a cotton cloth not being felt. So that is only the reason why I put the posterior column involvement query, because I
Yeah.
had
Do you really think that is
so it could not
indicative
it,
of
so
posterior column involvement?
it shall not be, sir, most probably posterior column. The fine touch only component that could be very subjective on history also. So we can say that posterior column may not be involved as of now, sir.
Yeah. See, you're complicating your own history and leading to confusion for yourself by doing all this,
Sure, sir.
isn't it?
So I had this confusion. I was not able to understand what to do. So
Correct.
I
Correct. So
could
when you have such confusion, it's better
better
that you
to
just,
sure,
ensure that the other components of the posterior column are involved or not. Otherwise, just forget about it.
sure. Understood, sir.
Yeah.
Sure, sir.
See, in
Sure,
your
sir.
own mind, you should have great clarity about uh, what what substrate is really involved. If you confuse with such minor things and think this is posterior column, then
Then
it'll
I
be
think
difficult for you to justify it eventually.
agree, sir.
Yeah.
So I just one doubt, like what Anand sir told, like in regarding the vertical extent from here, like as sir you are told CBJ, sir. So like when you had asked me in the previous case, I had this mind that spastic quadriparesis to be localizing to CBJ, but then it can happen for lesions even starting at C4, C5. So how would this spastic quadriparesis specifically localize to CBJ?
Ayush, when we say below foramen magnum or below CBJ, till
Mhm.
C5 means the pathology can be anywhere from CBJ to C5.
Understood. So I
When
need
That
we are
is,
not
not
give
saying we are not saying that pathology has to be at the CBJ. When we say the pathology is below foramen magnum, above C5, it means the pathology can be anywhere between that. It could be a C2 neurofibroma.
okay.
Okay,
Understood.
it could be a C3 meningioma. It could be a syrinx at C extending from C2 to C4 or C5. What we
Okay.
mean is that your localization as per the history, like in the in the previous
Understood, sir.
case.
But then I misunderstood. My logic was like where I
I
get from the history the particular point
I
and
think
not
Santosh
go.
sir wants to add something. Ayush, Santosh sir wants to add
no,
something.
we discussed it in the previous case, Ayush, that it is extremely difficult. Like Dr. Anand said, to localize between the foramen magnum and C5. Very, very difficult to localize. So it may be simpler to say that it is high cervical cord compression
Okay.
or high cervical cord involvement, above
Sir,
C5.
sir,
Unless you have very clear-cut indicators that something is giving you a clue as to specific involvement.
okay, sir.
Yeah.
And like regarding the vertical extent coming down to C8, since my patient had hand wasting, so that I should say it like CVJ2 to C8 or T1. That should I should make my entire cervical expansion part as my hot vertical extent.
I think if you have wasting, certainly it would go to C8T1. No?
Okay, sir.
So I think there you're right. Absolutely right.
Understood, sir. So shall I proceed to the examination part?
I guess yes, Ayush.
Yeah.
I
Patient
think
was
the
alert
focus,
for
Santosh sir, I think we can
Ah,
request him to focus only on the relevant findings rather than the anemia and pulse and blood pressure.
correct, correct,
You go to the relevant findings, okay? You tell us the positive findings and the important negative ones, okay?
correct.
so over here, there was no presence of any neurocutaneous marker. The single
Okay.
breath count was 32, diaphragmatic movement normal. There was no use of accessory muscle. Now, in the local neck examination, neck movements were full and painless, tenderness absent, no short neck was present, neck height ratio 0.04, low posterior hairline present, webbing absent, Sprengel deformity absent. CNS examination was within normal limit. Cranial nerve examination was again within normal limit. Uh, Coming down to the motor examination in muscle bulk, I could on measurement by anthropometry, I could appreciate that the right side appeared to be weak and there was wasting of thinner muscles of both the hand. Tone was increased in all muscles, Ashworth grade 2. Then the power was reduced in both the limbs. Uh, and it was symmetrical loss of power in both the limbs, and the In the neck muscles, I could only appreciate the weakness of the trapezius. There was no weakness of the sternocleidomastoid, and he was able to lift his head from lying down position, but there was difficulty in lifting both legs in supine position against resistance.
Ayush, can you just go back? So what do you mean by difficulty in lifting both legs in supine position against resistance?
So I was trying to check the truncal muscles, like if he could both lift both the legs above
Truncal
against
muscles means which muscles?
some main of the hip flexors and the abdominal muscle, the quadratus, lumboris, and
So you want to examine the quadratus lumboris, and by examining
no,
this difficulty in lifting the leg.
I'm confusing it with something else. Sorry, sir, wrong answer.
Anyways, what Santosh has said na, just a couple of minutes ago,
Yeah,
don't
not to
say or such things in which you will get entangled. The examiner, see, you already mentioned about the hip muscles and the knee muscles. Why do you want to write such things and get yourself in a soup?
Sorry,
No?
sir. Understood, sir.
Okay, okay, go ahead.
See, I would like to again emphasize here, Ayush, that all these so many histories, so many small findings you are trying to elicit, and you are confusing yourself. So you should, right from the beginning, your thought process should be clear from your history, where the pathology is. From the history, you should be able to know the vertical and horizontal extent from the history. I'm talking of history, and only confirm it by examination. Another thing is, an examination will rarely tell you the etiology of the pathology. It will only tell you, the history is the only thing which will give you the etiology of the condition. So instead of getting into very minor details and ending up getting confused yourself, a clarity of thought has to be throughout the process. Only then your flow will be smooth, and you will come up with a clear-cut diagnosis at the end of the whole thing. Yeah.
Understood, sir. So the reflexes were exaggerated on the both the side. I was even even the pectoral reflex. Sorry for the spelling mistakes. The pectoral reflex was exaggerated both the side. Bilateral ankle clonus was present. Bilateral Hoffman sign was present. Superficial abdominal reflex was absent in all quadrants. Then the sensation, touch was preserved over face and trunk and mildly impaired over the upper limbs. Pain and temperature diminished from C4 downwards, maximally in the C4 to T8 dermatome with a classic cape distribution. Posterior column vibration, joint position, pressure sense intact. Cortical sensations were preserved. Cerebellum was within normal limit. Gait was a spastic scissoring gait. General systemic examination was normal. So to summarize, a 16-year-old boy present with an 8-year history of incidence onset, gradual, progressive, asymmetrical spastic quadriparesis, initially involving the right lower limb, followed by the right upper limb, left upper limb, left lower limb, affecting both fine and gross motor functions with intrinsic hand muscle wasting, associated with dissociated sensory impairment, predominantly affecting the pain and temperature sensation, beginning in the C4 distribution with preservation of posterior column and autonomic functions. Examination demonstrated low hairline, short neck, bilateral corticospinal tract involvement, anterior horn cell involvement at the cervical enlargement, spinothalamic tract involvement, and no autonomic involvement and the posterior column involvement. So substrates, so I would change my substrate over here. Now it would be vertical from CVJ to C4. Like after the discussion, horizontal would be corticospinal tract, spinothalamic tract, anterior horn cells, and I would remove the posterior column and substrate. It would be likely to be an extramedullary, and again I would like to change the etiological substrate over here, probably an extramedullary lesion between from CVJ to C4.
Snehal,
Yes, sir.
you agree or disagree with this substrate involved and the localization that he has put up?
Sir, vertical extent will be CVJ because stigmata of CVJ are present in the form of short neck and low hairline. And the patient has cape distribution, according to him, C4 to T2 sensory loss is there. So could be syrinx, like intramedullary plus extramedullary pathology. Dissociated sensory loss is present, along with corticospinal tract involvement and CVJ stigmata.
Why can't it be a simple intramedullary pathology? Why do you want to say it is an intramedullary with an extramedullary pathology?
Patient has short neck and low hairline.
Okay.
Spastic quadriparesis.
Spastic quadriparesis can be present even in intramedullary pathology
Yes,
also,
yes, sir. Yes, sir.
because this patient has a classical dissociated sensory loss and has a
Yes,
clear
sir.
sensory loss.
Yes, sir. It goes more towards intramedullary pathology. Patient has trapezius weakness also.
So, but
Upper cervical level.
what is against an intramedullary pathology?
Against the pattern of weakness was against the intramedullary pathology.
And that was in history in examination, or even on history examination, bladder bowel involvement.
There is no bladder bowel involvement, sir.
So that goes in favor of intramedullary, or that goes against intramedullary?
Against intramedullary side.
You have to mention all these things, now. You
Yes,
have
sir.
to always tell us what are the points in favor of a particular localization or pathology or your substrate involved, and what are the points in favor and what are the points against it. Okay.
Yes, sir.
Santosh, sir.
I think this is fair enough. We move ahead. Let's go to the.
Okay.
So I have
Ayush,
the
please move.
radiology, sir, for the same. So this was my CT scan of the patient, and I have some MRI images, sir. Like what I could actually appreciate was probably a odontoid tip of odontoid fracture over here. Should I proceed to MRI? Should I show the MRI also, sir?
Yeah, okay. Snehal, you want to see anything else in this?
Flexion, CT
Okay.
flexion.
Ayush?
Yeah, so
Yeah, move ahead then. Yes, Ayush?
yes, sir. I have one more image, sir.
Okay. So Snehal, now what is
Yes,
the
sir.
final diagnosis after this? After you have seen after you heard the history, the examination, and now the radiologies, go
So
to the
patient is
sagittal one, the sagittal T2 one. Yeah, Snehal, please.
So patient has long segment syrinx with long segment syrinx up to lower dorsal region and has Chiari also, sir.
So he has tonsillar descent, tonsillar herniation. Snehal?
Yes, sir.
Yeah, so why are you saying the patient has a Chiari?
There is tonsillar descent,
Okay.
long segment syrinx.
Okay. Santosh, sir?
Yeah, I think I would agree with her.
Yes, sir.
Yeah.
Yes, sir. Yes, sir. Okay.
Oh. Nobody does plain X-rays these days. Flexion extension plain X-rays before you move on to directly to the MRI.
So the X-rays were done. I didn't add over here. Sorry, sir.
Okay. Fine, fine. So I agree. There is tonsillar herniation. There is
Yes,
long
sir.
segment syrinx.
Yes, sir. Yes, sir.
So
Okay,
now
so
what would you
yeah.
like to do for this patient?
So the patient has os odontoidum also. like to see if the
So Snehal,
stability.
he said that sorry, Ayush said that he thinks that there's a odontoid fracture. You are saying it is an os odontoideum. So how do you differentiate a odontoid fracture from an os odontoideum?
So the margins are corticated on the CT scan.
Mm-hmm.
Ayush,
Okay.
can you shift to the CT scan?
Yes, sir.
So Ayush, would you like to defend yourself or you agree with what she is saying? You said it is an odontoid fracture. She is saying it is an os odontoideum.
And if you agree, like, can you mark out the margins of what Snail is saying? Because I am unable to make out the margins and the fracture and everything.
I wish you had larger images, we're not able to see too well.
Ayush, I think you can zoom it at your end.
Yeah, you can zoom it, or you go out of the slideshow and then you can zoom it, or try to zoom it.
Or just a minute.
Yeah, now go to the CT fine. Go to slide number 30. Yeah, now you can zoom it. Yeah.
Yeah. Yeah, the top right cuts. Yeah, enough. Bring it down, I think.
Bring it down. Bring it down. No,
Down,
no, no.
down. No. You're going up. Yeah.
Yeah,
Just
yes.
hold it there. Yes, hold
Yes.
it there.
Okay.
So, in which cut can you see the fracture, Snail?
So you're in the middle one, sir.
Do you think that is a fracture?
No. Fracture was said by Ayush. Ayush said it is a fracture, and Sneha said it is an osteoidium.
Yeah. So, Snail, how come there is
Do you
something
have
new that
coronal images, Ayush? You don't have coronal images.
even
I
in the
don't think
axial, actually, it is not seen. I think
that doesn't
probably.
look like
It's
discontinuation.
definitely does not look like anything.
Okay, so Snehal, what do you plan for this patient now? Leave aside the odontoidium or the fracture issue. What would you do for this patient?
So we'll see if the joint is unstable, then we'll have to fix it, sir. Flexion scan.
Only
CT flexion.
flexion or you need flexion extension both, or only flexion would do?
So flexion extension both.
Okay, let us assume let us have two scenarios. In one case in which there is instability, and another case in which there is no instability. So how does the management change?
Sir, we'll have to fix C1, C2, sir.
So how do you fix C1, C2?
Set by Goel's C1, C2 posterior fixation method, sir.
No. What is the Goel's method? What does Sir do?
Sir, so in prone position, we apply cervical tractions and keep the head in.
And that is fine. What fixation is used in C1 and C2?
So C2 pedicle, C1 lateral mass fixation.
Okay, and do you use cage?
No, sir, we use bone grafts.
Okay. And if there's no instability, then what shall be your plan?
Sir, we usually in our institute we do C1, C2 fixation only.
So then why do you want a flexion extension?
Yes, sir.
No. Snail, what Sir is
You see
asking is if you are going to fix anyway, how does flexion extension make a difference for you?
Sir, we'll see if it is reducible or irreducible.
Do you think it is irreducible in the CT scan? It is already reduced
No,
in the
sir,
CT
it
scan.
is reduced. It is in
So then
extension, it is
think
reduced.
before you are answering, right?
No, I think his question is if your management for reducible and irreducible is not going to be different, then why try and even find it out?
Absolutely.
Am I right? Is that the question?
Absolutely, sir. Yeah, correct, sir.
Yes,
Absolutely.
sir. Because she said that if it is unstable, then she will fix, and if it is stable, then also she will fix. Then what is the need to do on CTCVJ? CTCVJ flexion extension. You're getting a question.
Yes, sir.
So what do you want to look for? Okay. Anyways, chalo. So.
And sir wanted to ask, what do other people do? If
Correct.
it's stable,
I
then
was
our name.
coming to that.
Foramen
apart
magnum
from
decompression.
OL's management, is there any other way of managing this, and how would others manage this?
So since we have the component of Kyrie, we can do a foramen magnum decompression.
Ayush, your name is not Snehal, man.
Oh, sorry, sir.
Yeah.
Fine.
Snehal, please go ahead. The question is
Yes, sir.
directed to you.
Yes, sir. Yes, sir. We would do foramen magnum decompression, sir.
What is that? How much foramen magnum do you remove? You have to be more specific during these answers.
And only bony removal?
What are the various options available, Snehal? Apart from only foramen magnum decompression, what else others are doing, or what are the other options available to do? You could choose any one of them. There's still no consensus on that.
Yes, sir.
So what are those options?
Snehal, I really have to beg to ask you this. Are you using some kind of AI help, because it is taking too much of delay in your answers?
No, sir.
So I suppose you can just answer these questions immediately, right? There is too much of a
Yes,
lag.
sir.
It seems as if you're typing somewhere and then the answer is coming, and then you're trying to, it's quite obvious right now. Just what if you don't know, just go ahead. Don't know. It's not as if this is your final exam or something. This is just a preparation part.
Yes, Snail, it's okay, because at your center you might be doing you might not be doing fonomagnum decompression. You are fixing C1, C2. That is acceptable. Okay. I mean,
Yes, sir.
there is nothing right or wrong in this. It still is a developing thing. Okay.
Yes,
Anyways,
sir.
then Santosh, sir, then we can move ahead, and Harsh, we
Yes, sir.
can.
Yes, yes.
Right.
Prashant, would you want to start? Sir, sorry. Please go ahead.
No,
No, one
Santosh,
sec,
you
one
want to
sec.
add something?
I would like to, interrupt here. We haven't discussed the other options at all. I mean, it seems
Yeah.
that for tonsillar herniations with syrinx, fixation of the C1, C2 is the only option that is being discussed here, which I think sends a wrong signal to the
Yeah. Ayush,
students.
do you want to answer the questions which you are going to answer? What are the other options?
So what we do over here is like in our institute, like for normal Kyrie malformation, like we do a foramen magnum decompression. So we basically start from the craniotomy around 3 to 4 centimeter, extending up till the level of C2, C2, and then the other option is like putting a duraplasty or not duraplasty, doing a duraplasty or not duraplasty. So there is no such consensus over here. But in order to prevent leaks in our institute, we usually uh, prefer to cover it with a uh, dural substitute.
So
NR
what
and
I'm understanding is you do a fonomagnum decompression, and then you open up the dura, and then you
yes,
do duroplasty. Okay. This is what you are
yes,
saying, Ayush?
yes, sir. A lax duroplasty, basically.
Lax duroplasty. Okay. Anything else can be done?
So many
Yes.
people just prefer just removing the bone, and they don't like cut
Okay,
this.
so one option is only doing the fonomagnum decompression without opening the dura.
Hmm.
The other option that you mentioned is fonomagnum decompression with duroplasty.
With
Anything
duroplasty.
else can be done?
So ma'am, like foramen magnum decompression along with fixation, मतलब the combination of both.
The
Okay.
fixation part is over, Ayush. Anything else apart from
Anything
that?
else can be done?
So I'm not aware. I've like just seen these three particular parts.
Okay. Can you do something with the tonsils?
Correct. That will get probably.
So
Ayush, can you do something with the tonsils?
started hinting towards removing the tonsils, like excision of like removal of the tonsils, dissect. I'm not seeing them, so I'm not quite sure.
Ayush, I mean, in life, there are some things which you will not see in an institute. That does not mean that you have not supposed to read them at all. I'm quite surprised that both of you are just answering that this is done in our institute. So that is all we know. There are books available. There are so many things available. Very, very, I'm quite surprised. I mean,
So
Anything to do with
Yeah.
OBEX?
See, when you are discussing treatment, surgical treatment, you need to know all the various options that are
yeah,
available for you.
absolutely. Absolutely, absolutely.
You can't be dogmatic about this is what I do. It take you maybe 30 more years to come to that stage where I only fix for tonsillar herniations. What are the various options? You have to describe all of them. No, you could have only bony decompression. You could have some people only open the dura and leave the arachnoid intact. There is a third set of people who would do a duroplasty. There is a fourth set of people who would go in and do a subpile excision of the tonsils and completely free the obex. So all these options you are supposed to know when you are appearing for the exam. You can't just say, I do this or my center only does this. Yeah.
Ayush, you mentioned something about C2. Do you also remove C2? Is it mandatory
Yeah,
to
that was
dissect
very
C2 off?
surprising. I mean, yeah.
No. Normally C1 is only if it like sometimes we have seen like
Yeah, it is
extending
going
below.
down to C2 is fine. Sometimes it's fine. I do not.
Not on a usual basis. Not on a usual basis.
It's like we have two extremes. One person is not answering anything, and the other person is over answering in this whole situation.
Sorry,
You
sir.
tend to overstate, in fact, and the other person is probably, I don't know, not answering anything. It's like very extreme situation here. Okay, fine.
So one more thing I would like to add, some people go and do a syringostomy and put a syrinx subarachnoid shunt also.
Yes, sir.
Exactly,
So
sir.
all these
Absolutely.
options you have to at least enumerate. Then
Yeah.
the examiners will ask you, what are you doing at your center? And what do you think are the results of it? You can't just be dogmatic about it that, oh, we just do this, that's it.
Sorry, sir.
Okay.
Yeah.
So all the options should be presented, and then maybe you can opine if the examiners ask you, what in your opinion is the best modality that you would like to do, or what is the treatment that is followed at your center. Okay?
Yes,
sir.
sir.
I
Prashant,
think
you
we
want to
can
go?
move
Yeah,
on.
yes, sir. We'll go ahead. Prashant, your OSCE first, I think.
Yeah, I'll do that.
So, Ayush, you will be answering Prashant's OSCE.
I'll come. Harsh, can you see my screen?
No, no, not yet, not yet. I think we can see you, but your screen is not yet visible.
Okay, I'll just share that screen. Yes,
Yeah,
now
I
I
think
think.
now I think it's
Yeah,
visible. Yeah.
now it is.
So, Ayush, this is for you.
See both the videos, Ayush, and identify the aneurysm shown. If you want me to play the video again, I'll do it for you.
So please play it one more time.
Yeah.
Yeah.
So if I'm not wrong, ACOM aneurysm, so
ACOM or PCOM? I didn't get you, so I'm asking.
so I have told ACOM, so I'm not told
Okay.
PCOM.
Okay. So that is an ACOM aneurysm. What are the common projections of these aneurysms?
So common projections are like
You understand what I mean by projections?
the no the
Where does the
direction of the
aneurysm?
fundus.
Yeah.
also mostly they are like direction is more of superior and superiorly directed.
Is superior the most common?
No, ACOM we have inferior. Have like confused. Most probably it's inferior and laterally directed are the most common.
I don't.
So I'm not aware of this, and I'm not able to recall right now.
Okay. Can I ask Nehal, or should we proceed to the next question, Harsh?
I think we can go ahead to the next question. If Snail wants to answer, please go ahead.
So directed inferiorly at most common.
Okay. And Ayush, which artery should be visualized before applying the clip?
The one which you mentioned, recurrent artery of Huebner, because of the chances
Only that?
The question is arteries, Ayush. There's a clue in the question.
Sorry.
See, Ayush,
I mean, the opposite side.
That is saying something.
Sorry.
Just
Yes,
read
sir.
Which artery should be visualized before applying the clip? It is not only the recurrent artery of humor.
Yeah.
What
So
are
we
the
need
other
to
arteries that you want to
the
visualize?
opposite side artery. The opposite side artery
What
needs to be
artery? Which
the
artery
opposite.
you want to
So the
visualize?
opposite side, A2.
I think what
There are
he's is I'm not too sure. I think he's reading the answers that the people are putting up in the chat box.
Yeah.
oh, but
Ayush,
there
have
are
you
a
seen an
number of
Just
ACOM
click
being
on
arteries.
clipped?
contralateral A2.
Sir, I
If
have
you want
seen.
to,
You have
I
seen
have
an
seen.
ACOM being clipped, no? So what all
Yes.
arteries did the consultant dissect off while doing it? Just try to remember those. Go
So
in sequence. First, I think he must have dissected the Sylvian.
Sylvian
So you must
dissection,
have
and
seen ICA probably.
probably
Then he
then
must
he
have
saw
gone to
the
A1. Then
bifurcation, and then sir traced the artery from A1, and then the when he thought it to be ACOM, then he went towards the opposite side and traced the opposite side arteries originating.
which one?
What
arteries
arteries?
In the
means
side
arch of
A1 or A2?
aorta, pudendal artery. Which arteries, man? There has to be some name to those arteries, right?
Some books mentions as great good number 11 arteries. Some say 7 arteries are enough.
And there is a pattern to it.
Yeah.
You can't randomly go on dissecting.
I'm not able to recall them, sir. But
Okay. Can you
Neil,
see
you
this
want to
video?
answer these?
So A1 of both the sides
Then
Ipsy and contra A1, okay.
and uh, so A2 and perforators.
it's
Oh,
a typical AI answer, man. Chalo, khair. Okay.
okay. Now, Ayush, about recurrent artery of Hubner, can you identify recurrent artery of Hubner here? And tell us why it is called a recurrent artery, what is its origin?
so
And why is it so important?
And what does it supply basically?
the most common origin of the recurrent artery of Hubner comes from the ACOM A2 junction, where some do originate from the A1 ACOM junction, and it is important because of its supply to the internal capsule and the basal ganglia area. So damage to this can lead to infarct and the paralysis in the postoperative period.
You could be more specific regarding the basal ganglia and also regarding the weakness and deficit.
Absolutely.
What
So
kind of?
the part of thalamus, thalamus, and the weakness in the post-op period would be the lower limb weakness.
I think you were right about the internal capsule, and it can cause hemiplegia. Why, you can read it. Should I proceed to the next question, sir?
Yes, please.
Can you identify the lesion, Ayush? Can you
Uh,
just describe the lesion, if not identify it? And
So the
just describe the lesion based on the scans in front of you.
so the first is a CT
This is the same
angiographic.
lesion all around.
Yeah. The first image that is given is of the CT angiography. So it shows the blood vessels entering the tumor and supplying it well. The second is the MRI, probably a contrast image where we have the contrast, homogeneous enhancement of the entire tumor, and it is involving the cortical, the bone also up till the outer cortex, and
Intradiploic, you mean?
intradiploid along with the intracranial extension, and
Brilliant enhancement, you meant.
yes, a homogeneously brilliantly enhancement tumor, sir.
Okay. Okay. And
And
what is the
then
blood supply for the lesion? You can look at the other images also.
yeah, so the scan which you have given over here, so presumably it is involving the bone, and the blood supply is coming from the external carotid artery over here, the branches of the external carotid artery.
Okay.
Which would be?
Some of the branches over here we have so could be the superficial temporal the ending artery, superficial temporal, and then can be the facial artery. It can be maxillary artery, and
Okay.
ascending pharyngeal, And
No, don't go there.
Okay.
Don't.
I'm not a medial.
Okay. How would you deal with the lesion? What would be the plan? Any special plan apart from just going in and excising the lesion?
Yes, sir. So since it's a highly vascular tumor, I can plan for a pre-operative embolization of the tumor, sir.
Okay. And then going in.
Pre-operative embolization, and then within 48 hours to proceed for the resection of the tumor, sir.
Okay. Sir, anything else you want to ask? Or Harsh, you want to ask something?
What did this turn out to be eventually?
Sir, we
I
are
felt
going to operate it tomorrow, sir.
I felt that this is a meningioma probably.
It looks like a meningioma.
Yeah,
Yes,
there's
sir.
a MMA supply,
Dural.
intradiploic, extradiploic
Yes, sir.
component. There is dural involvement also.
Yes, sir.
Could be a hemangioperiscytoma also.
Yeah,
That is the first
Yes, sir.
diagnosis actually, sir.
that is
Hemangioperiscytoma and then meningioma.
Interesting tumor.
Yes, sir.
yeah.
So can we call it a typical meningioma?
Typical.
No,
It's
not
taking
so much.
origin in the interdiploid space. Okay,
Sure,
Harsh,
fine.
you'll share
Yeah,
your
I'll
screen.
do it. Yeah.
Just
Okay. Can you, Snail? I think
I'll
this is for you.
Yes, sir. Yes, sir.
Yeah. So this is an image. Just see the images. Okay, I'll show you one more image after this. Once this stops. Okay, this is the other image. Okay, you've seen the images. Okay. So the question is, what is your diagnosis in this case? I'd request, please don't type the answers. I mean, ultimately, it is Snail who is losing out here. Snail, what would be your diagnosis in this case?
Sir, it is D1 extramedullary lesion, sir,
Okay,
showing
which would
post-contrast enhancement.
question still remains, what is the diagnosis?
S- It's most probably a meningioma, sir.
Fine. So, if it is a meningioma, what is your plan for this case?
Sir, excision of the tumor, sir.
From the sacral root, from the nasal root, from the cranial root? You have to be specific, Snail. Cannot answer like this.
Yes, sir. Posterior laminectomy and excision, sir.
C1 laminectomy, C2 laminectomy.
C7 D1 laminectomy, sir, and
Okay.
excision.
And you would fix, not fix.
Sir, since it is a single level small tumor, will not fix you.
So you
Snehal,
want to
please
do a
take into account everything and then answer.
yeah. Think over it. This is a C7T1 lesion. This question has been kept for a specific reason. I have not just kept it just like that. A lot of thought gone into putting a question.
This Nehal, Dr. Harsh is
Yes,
giving
sir.
it is a T1. So what is so specific
Yes, sir.
about T1?
This third question is also giving you a clue. What are the prognostic factors specific to this case? The question itself has a clue in this. So what do you think are the prognostic factors specifically for this case, considering the location, what it is?
Sir, it is dorsal, so might cause paraparesis.
That I think probably anyone can answer from first MBBS. That I understand, but what specific? If you are very very careful, you can see something below also.
Yes, sir.
So would you still want to just do a laminectomy and come out? What does this give you a clue to? What does this give you a clue to?
Butterfly vertebra is there, sir.
So what does that mean? What does this patient? If I do a CT of this patient, what does that mean? Snail, if you don't know, you can go ahead. I mean,
Sir,
I think Harsh, you should move ahead and
yeah.
so
So
she
this
can
this
get in
this
position.
means that the patient has osteoporosis. This is a wedge compression fracture. This is a
yeah.
C71 junctional region. Either you do a laminoplasty and fix it back, or you fix this lesion before you come out. Because this patient will have severe kyphosis in the long run once you remove the lamina completely, being a junctional. Second answer I would have expected from you is that this is, since a D1 to D4 lesion, there is something called as a watershed area which is there. Okay, chalo, what? Okay, this is the second case. Look at the images carefully. Take your time. This is not an easy answer, but take your time. Something I believe that you are an expert in. Look at the cursors where they are going. Okay, there is another image which I can show you in this case. Now look at these images also. Okay, so the question is, what does Pro Atlas give rise to?
So Pro Atlas gives rise to sir, tip of clivus and tip of odontoid and sir, part of occipital condyles.
Going everywhere. Okay, what is the diagnosis in this case?
Sir, basilar invagination and atlantoaxial dislocation both are present.
Great. What is the peculiarity in the CT angio?
Angio,
You want to look at it again? I'll show you again. No
yes, sir.
problem.
Yes, sir.
Yeah, sure. Take your time. No problem. There are two peculiarities, if I'll give you a hint. Even if you can tell one of them, it will be great. One of them is very obvious, actually. The other one
Right.
might not. Yeah. Tell me.
Persistent inter
No, it's not that difficult.
segment.
Do not make it overcomplicated. It is quite simple, actually.
High riding this thing is also vertebral artery on right
High
side.
riding needs sagittal, man. This is the sagittal. Do you still think it is high riding? Or is it something else? Something which every CVJ surgeon fears before going in.
Now you can see.
Yeah. See the cursor. The video has been made very specifically for that reason. I have screen recorded this very, just specifically for you to see.
You were on the right path when you said something about vertebral, but that was
Yeah.
not the correct answer.
Okay. Well, so now what is the peculiarity of the CT angel? Let us finish this. It's getting late now.
So can I attempt?
Yes.
Let her just finish off. Then please go ahead after that. If you cannot go ahead, we'll move ahead with the. There are two more questions in this. We'll go ahead with this.
Yes, sir.
Okay. How will you approach this case? What do you think your approach should be for this case?
So posterior C1, C2 fixation.
So that will fix the AD in the unreduced position with the BI still remaining, right?
Yes, sir. Distraction and fixation.
Okay, distraction with what exactly?
So
How are you
intra,
going to distract the joint? Do you place something inside the joint to distract it?
yes, sir, with bone graft is
So
placed
these
with
things have to be
cement.
told, right? Okay,
Yes,
okay,
sir.
fine. In case of
Ayush, you wanted to
VA,
attempt. Okay.
yeah, in case of VA injury, what are the rescue options?
Sir, we'll try to first control the bleeding by Surgicel, and if it is short segment, then we can even suture it. If not, then we'll have to coagulate the.
Ooh,
Nehal,
that's good.
see the question, what is the
Anand
rescue
sir, you want
option?
to pitch? Yeah.
It is
Anand sir.
not, see, coagulating the vertebra artery is not rescuing Dina. What are the rescue options? What all things can you do? Say, for instance, there is a minor injury to the vertebral artery or there is a major injury to the vertebral artery. Let us phrase it this way. What do you want to do in a minor injury? What do you want to do in a major injury? क्या
Uh,
करोगे आप?
so
You
stop
don't
the
coagulate
bleeding.
the vertebral artery, ना? क्या करते हो आप?
Yes, sir. Stop the Surgicel, sir, and applying pressure over.
Okay.
Okay, now Ayush, I think this is your moment to shine. Go ahead.
No, 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 nothing. So if like picality in CT angio, was it the if you were hinting to the low origin of the PCOM that is arising from the
So I somehow overestimated you, I suppose. So this is a
I,
unilateral vertebral artery. There is only
I
one
think
vertebral artery in this.
someone answered this in the chat box also.
Yeah, yeah. And if you look at this angio very, very carefully, the unilateral vertebral artery is just behind the joint. So those are the two peculiarities. The joint has been shown in the SAG image, and you can see that it is directly behind. There cannot be a better example for this. Like this is the joint, this is the vertebral artery. This is the joint, this is the vertebral artery. So if I ask you, Snehal, which side will you attempt your fusion first? The so eloquently answered fusion. Which side would you attempt it first?
On the side
Snehal,
of
are you
vertebral
still
artery
there?
or on the other side?
So
I
on the
think
other,
she's logged. Yeah, go ahead, please.
so on the other side, where the vertebral
That
artery is hypoplastic,
okay. That side would be the
first to fix
yeah. That probably is the left side artery in this
left
case,
side,
right?
left side. Yes, sir.
Ayush, you want to answer the last question? What do you do in case of VA injury?
some so I can attempt so like the minor if it is a minor injury, as you told, like putting Surgicel and all. Major injury, if it is repairable with the help of graft. If not, then the shifting the patient to the DSA room and stenting or putting a flow diverter. So in order to preserve, because if we remove the entire, if we do not, if we occlude the entire vertebral artery, that can have lot of direct consequences in the post-op period with complete uh,
In
loss of supply.
Anything else surgically you can do, and flow diverter not so much. Covered stent, yes.
Covered stenting.
Yeah. So anything else
flow
surgically?
diverter will not work at the level of CVJ, okay?
Exactly.
Vertebral
Yeah.
artery is too much tortuous there. You cannot apply flow diverter
Yeah.
there. Very
Yeah.
difficult.
Absolutely. So anything else surgically apart from coagulating and
By
suturing?
taking a graft and
Yeah, somewhere near that line. One word is at least correct. What kind of graft?
oh, so we can take the autologous graft over from the saphenous vein. No, sorry, not saphenous. The internal mammary artery, like
Too much.
saphenous.
So what I would say is that first you have to look at the PCOMs first before you go ahead and do anything in this case, especially in this case, right? So but you're partially right. What you have said is almost correct. Something else that you can do is you can attempt a high flow bypass around the injury. But the problem with usually these cases is unless the PCOM is okay, the amount of time it takes for you to take a radial artery and keep it ready and then do a bypass is usually not that. And the way where it gets injured, that area is also usually quite difficult to isolate. So always attempt the non this thing dominant part first. Sir, anything extra you want to add, sir? Anand, sir?
No, that is fine.
Sir.
See, even repair of the doing a bypass sometimes would be very difficult.
Yeah.
So some I think you have covered it quite well. Those are the only things that can be done.
Yeah. Santosh sir, anything to add? And please, sir, feedback for both the
Yeah.
students.
Yeah, I think there's a sort of dictum that
Sir, and please be frank because they have some time. So please
yeah,
be
yeah.
frank to them.
So
It's not a final exam; they're just preparing.
I
Yeah.
keep telling my students, the thing that I say is let knowledge flow. Let it not be extracted like a painful extraction of tooth. So, everything you have to keep on giving them hints, only then some kind of answer comes. You should have a flow, the whole thought process should be very clear, and you should cut, just go on saying one after the other. This is what I'll do, this is what I'll do, this I'll do. These are the options for rescuing in the event of a vertebral artery injury. One, two, three, four. So this is how you have to prepare. You can't, just go on thinking about it, and one by the examiner asks you something, is there something else you want to do? Then what else would you like to do? The best example of this was that fusion for foramen magnum,
Yeah, that was great.
so you need to have all the options. You're not there to champion your own
Yeah, I agree, sir.
modality of treatment. You have to have all the options available to you. Just as you have to have a differential ready, you have to have all surgical options also ready. And then, as you mature and as you go ahead, you choose what, in your opinion, is the best in your hands. So I think that is my comment on these students.
Anand sir.
They need to polish it up a little.
Yeah, I completely agree with Santosh sir. And just to add, your history taking was very inadequate. Sometimes what you have to understand is that you have to bring, as Santosh sir said, that if you ask your questions properly, if you listen to the history properly, and if you analyze the history properly, you will, in majority of the cases, you will be able to localize, and you will be able to even pinpoint the pathology as well. It is very important that your history taking has to be very spot on. Secondly, as sir said, we had to actually unfortunately extract all the answers from you. You should be more open with your answer, and you should be ready to accept what the examiner is trying to see. No examiner is trying to pin you down. No examiner is trying to fail you out there. Or examiners are trying, they might be giving you hint. You should learn how to pick up those hints so that you can answer according to those hints. And as Santosh sir said, and Harsh also said, don't be dogmatic with your answers that only this is the correct answer. The answers might actually see medical science is a very evolving science. Things keep on changing on a very rapid pace. So today's gold standard might be tomorrow's um, treatment of archaeological importance. So just be open to the discussion. Just be open to the answers. You should know all the options available for any treatment modality, and then you should choose what suits you. I mean, that is the only thing that needs to answer. And I think both of you should learn how to say the answers. You're just too quiet at some point, or you were just over answering at some point. There has to be a delicate balance
Yes, sir.
between answering it correctly.
Thank you, sir. And I thank Santosh sir and Anand sir once again, and thank you both candidates as well. You need to brush up your knowledge and your answering skills, as both the examiners have
Yes,
told
sir.
you. And I thank everyone for joining. Thank you, Harsh.
Thank you.
Thank you. Thank you so much.
Thank you.
Thank you.
Yeah, pleasure.
Thank you, sir.
Thank you, sir.
Thank you.